Thank you also, Vinny. That was great. Really appreciate that. I think covering the interoperability along with the systems improvement is fantastic. I now get the pleasure of introducing our next speaker, who is Jeremy Kahn, coming to us from University of Pittsburgh. He's a professor of critical care medicine and health policy and management there, and also at the Graduate School of Public Health. He's a core faculty member in clinical research, investigation, and systems modeling of acute illness at the Center in the Department of Critical Care Medicine. He directs this CRISMA program. And Dr. Kahn's research focuses on the organization, management, and financing of critical care services in the United States. He has interest in ICU workforce and staffing, quality measurement, benchmarking, telemedicine, and regionalization of critical and emergency care. So his work cuts across the fields of epidemiology, health services research, health economics, and organizational science to look at novel strategies for increasing both quality and efficiency of care for the critically ill. Welcome, Jeremy, and we're looking forward to hearing about policy approaches in the world of trying to improve sepsis diagnosis and sepsis care.
Thank you so much. Thanks obviously to the National Academies and the Gordon and Betty Moore Foundation. This has just been an amazing workshop and an amazing session. A lot of this session has been taking a step back to think about the system level, and I'm sort of taking the ultimate step back in my talk, thinking about what can policymakers and governments do in the effort to improve sepsis diagnosis. Next slide. This is just to acknowledge my disclosures. I have no commercial relationships, but get funding from a variety of governmental sources. Next. So I think the first thing to think about when we think about the role of policy in this issue is what are the levers that governments have to improve quality in general? And they're really a very limited set of levers. So for the most part, there are market incentives, right? So we can use public reporting, for example, to drive patients to high-performing hospitals, and then we can allocate resources. So a classic example of this is the HITECH Act, which essentially funded hospitals to adopt electronic health records. So resource allocation is really the second main policy lever. And then the third, and then one is that is fairly novel, is this idea of more of a regulatory approach. We haven't really taken regulation as a step to improve healthcare quality for the most part. This is at the national level is really about hospital accreditation. Most other types of regulations occur at the state level, but in sepsis in particular, and I'm going to talk about this in some ways, we have just started to mandate performance through these regulatory levers. And then when policymakers are also payers, an example might be Medicare and Medicaid, then we can use pay for performance, right? We can use financial incentives to improve healthcare policy. Healthcare quality. Next slide. So in this landscape, there's not been much effort really, or much headway, I should say, in using any of these levers in the realm of diagnosis. This paper is now almost 20 years old, really a landmark paper by Mark Raper and others that really first got the discussion about our missed opportunities to think about diagnostic quality and the rest of the performance improvement landscape. And this paper had no specific policy recommendations, right? They did say that oversight agencies need to balance their standards by including performance evaluations, focusing on diagnosis, but that's a pretty vague statement. Next slide. And then, of course, fast forward now 13 years to this landmark report that also had no policy recommendations except those related to malpractice and liability, and that we need to modify the regulatory landscape around malpractice to make diagnostic errors more of a front and center discussion. And now that's not to say that this was huge missed opportunity here. This is just to highlight that this is incredibly hard, and much smarter people than me have thought about this. I wish I could tell you that I'm going to have the solution to how we incorporate diagnostic quality into policy. I don't, but I do have some general thoughts. Next slide. So first we have to ask ourselves, well, what are the challenges here? Why haven't we adopted diagnostic quality into healthcare policy? So for one, the technology that we have is not up to the task, at least yet. Specifically, the diagnostic quality is just extraordinarily difficult to measure, and pretty much the majority of talks in this workshop have at least touched on this notion, right? And I'm not gonna solve this, except to say that we need to at least position the policy frameworks that we use in the policy landscape to anticipate a future where we will be better at using and diagnostic quality measures in some of these programs. But aside from that issue, there's these more inherent trade-offs that the domains of diagnostic quality underscore these unintended consequences. And there's really two domains of diagnostic quality, right? Efficiency and accuracy. And there's key trade-offs in each of these domains that really demonstrate the possibility for unintended consequences. And I think both Hallie and Vinny even mentioned some of these, this idea of misdiagnosis and overdiagnosis. And we've been a bit reluctant to rush diagnostic quality into the policy landscape, in part because of these unintended consequences and fear of doing more harm than good. Next slide. And not only have we not really done this, but actually the existing policy landscape probably does more harm than good related to diagnosis. Specifically, that these existing policy approaches, which are all about measuring performance using process of care and are very treatment oriented and very single denominator oriented, actually make diagnosis worse, right? So in this classic example where I want to say what proportion of patients with sepsis received antibiotics, I can actually improve my performance by lowering this denominator. So underdiagnosis actually makes me look better in things like public reporting and pay for performance. So we've actually got our incentives misaligned from the policy lens. Next slide. So what do we do? So here are some long-term solutions. So one is we just need to make diagnostic quality easier to measure. I am not going to solve that problem. That's for the really smart people in previous sessions who talked about machine learning and other informatics approaches to measure diagnostic quality. The other thing we can do, particularly when we get farther along this road, is to not just think about underdiagnosis as a fail, but also think specifically about overdiagnosis and late diagnosis, right? And if we measure diagnostic quality along all these domains, we can have a much more holistic approach. So for example, I have here 3 potential quality measures, and each of them lower is better. So less underdiagnosis, less overdiagnosis, and less late diagnosis. They all have separate denominators, but it's not too hard to think about that sort of multi-performance measure landscape, multi-domains, creating a single composite measure, and then incorporating these into existing programs. Now, I don't think that our ability to measure diagnostic performance is up to the task yet, but I think that it could very well be eventually. Next slide. So that's the long term. But what can we do right now? And I think we do have some ways that we can start incorporating diagnostic quality with sepsis, for sepsis, into the existing policy landscape. And I'm going to offer 2 concrete approaches. One is through adopting holistic policies that incentivize the entire clinical process, not just treatments, but also diagnosis through outcome. And then team-based policies that directly incentivize non-physician providers. Next. So to start with thinking about what a healthcare policy might look like that relates to diagnosis, I'm going to mention really the hallmark of a state policy related to sepsis, and that's the New York State regulations that are known as Rory's regulations. These are obviously in a lot of people's minds when we think about health policy related to sepsis. This is a very holistic policy adopted around 2013 in response to many, many factors, one of which was the tragic death of an adolescent whose sepsis went underdiagnosed. What these policies do is they mandate protocols for recognition and treatment, staff education, reporting of both process and outcome data, and they also mandate communication around diagnosis with families. And this is really in a soup to nuts sort of policy. It's a heavy hand indeed, in that it addresses really all 3 domains of the Donabedian framework for healthcare quality, right? Structure, process, and outcome. Next slide. What was the impact of these? So there's a bunch of different studies. Here's one that we conducted that was published just last year. We compared what happened in New York State to very similar states, or at least the most similar states that we could find, because there aren't too many states that are perfectly similar to New York. And it was pretty evident, this is mortality, that other states, the control states in the blue line, adhered to their projected curve. But after the policy, New York in the red state was sort of knocked off its projected curve with dramatic reductions in mortality that would not otherwise have been expected. And that was highly statistically significant. So pretty strong evidence that this very holistic policy did have a substantially positive impact on patient outcomes. I want to contrast this policy to another policy, right? The main government policy related to sepsis, which is known as SEP1. Next slide. So what is SEP1? This is a federal policy. It's by far and away the largest health policy related to sepsis to date. And in contrast to Roy's regulations, instead of being a multi-component policy, it's simply public reporting. So it's a single component. While Roy's regulations in New York affected structure, process, and outcome, SEP1 affects process only, right? It only says, are you adhering to a resuscitation bundle for patients with sepsis? It doesn't look at what you're doing to accomplish that bundle, which Roy's regulations does, nor does it look at what the clinical outcomes are. And then Roy's regulations has this really unique emphasis on education and protocols. SEP1 is just very traditional, right? Data collection and reporting. It's everything that we've done at the federal level for years. So what was the impact of the CMS policy? We don't yet have definitive answers. There's some early work that I'll show you on the next slide. This is work done by Ian Barbash, who's my colleague here at the University of Pittsburgh. There's no control states here, obviously, because every state was subject to SEP1, but this is 12 hospitals in the UPMC health system where I work. In the top slide, you can see what happened in the process of care, and there was not a substantial influence of antibiotics and fluid use, but there were a lot more lactates measured in the post period in response to SEP1. In the bottom, you can see outcomes, and there was no impact in mortality. So what we're seeing with SEP1, which is this much more narrowly defined policy, we're seeing actually some evidence of harm, right? We're seeing efforts to improve diagnosis, but in potentially the wrong way without impact in outcome. And we can definitely contrast that to New York State, where a much more holistic policy that emphasized structures, including education, led to improved outcomes. Next slide. We're following up our study in New York, our quantitative study, with a qualitative study where we're essentially going to New York hospitals and saying, tell us what you did in response to Roy's regulations. Why do you think it had the impact that we observed? And the answer is generally all about these educational interventions, right? All the nurses and physicians that we've talked to date have really emphasized this notion of actively participating in efforts to engage nurses and other providers in the emergency department. It's all about education. No one has mentioned what a joy it is to collect data and report it to the state of New York as a way to improve outcomes, right? So again, some qualitative data that shows that when we take this holistic approach to healthcare policy, we can improve outcomes. Now, to be clear, none of this is to say that the New York policy is perfect, and we can talk about ways to improve it. It certainly can be improved, but only to say that on the whole, the data would show that it is these kind of holistic policies that can potentially have an impact. Next slide. In my waning minutes, I want to mention this other policy. We're not quite ready for this yet, but it's worth at least discussing because I think it has not been discussed enough. And this is something that does flow right out of the National Academies 2015 report, which is this notion that diagnosis is a team sport. This was actually not just a recommendation of the report, but it was recommendation 1A. Hard to put this more front and center, and I think with good reason. Next slide. Who's diagnosing sepsis? Well, I spent about 10 seconds putting this slide together. There's probably more people, but I, in the 10 seconds, came up with 1, 2, 3, 4, 5, 6, 7 people that might be involved in the sepsis diagnoses. But of all of these, who is targeted by things like pay for performance and value-based purchasing? Only the last person on that list, right? This is a big missed opportunity, and I think we have not done enough to think through policies that could incentivize all of these people, specifically financial incentives. I think financial incentives and other behavioral economics approaches are very powerful. And yet why we've only thought about these at the hospital level and at the physician level instead of the team level, and how we can make all of these people accountable for diagnostic quality, I think is a big missed opportunity. So when we think about mandates, I think it's also nice to think about carrots and incentives for the entire healthcare team. Next slide. This is just to conclude. I think that to this point, we do need to admit that health policy has neglected sepsis performance, but it's for good reasons. And it's not just in sepsis, right? Like all across the policy landscape at the intersection between healthcare policy and performance improvement, diagnosis has been a bit of the redheaded stepchild, but we will fix this. This is going to change. The first thing to change this is to endorse the state regulations that emphasize structure, process, and outcome. I think the evidence does support that on the whole, these things do more harm than good. But in the future, we need to consider both refining those programs to make sure that they not only do more harm than good, but to minimize the harms and to maximize the goods, but also adopt team-based P4P. When we are able to have the technology catch up, we need to be prepared to incorporate diagnostic performance into public reporting and P4P, and then start thinking about giving resources for IT adoption to hospitals to help them along this journey. The levers that we have on the right are all going to help us figure this out, but it's just a question of being very thoughtful and being very intelligent and being context sensitive. And with that, I'll conclude. Thank you.